very much, Claudius, for this kind invitation. And I admire your work and what you have put together here. And it's an honor to be part of the people who are allowed to present and speak here. So let me just quickly share my slides. Okay, and so can you see my slides?
Yes, Samira, we can see.
Okay.
Clearly.
So I will be talking about maternal hemodynamics in SGA and FGR pregnancy. The maternal heart accomplishes an exceptional job during pregnancy. The maternal heart manages to increase the left ventricular mass during the time of pregnancy by 40% over a time of just 9 months. Please keep this in mind. If we compare this to elite athletes who train for more than 2 years, they will gain a left ventricular mass increase of around 20%. But how is this possible? The pregnancy alters the women's physiology in order to meet the demands of the growing fetus. And maternal hemodynamics changes, they occur from very early on in gestation. And by 8 weeks of pregnancy, the systemic vascular resistance, which is shown in this purple line down here, has already decreased by 10 to 30%. And this is possible due to a peripheral vasodilatation. And it's a reduced response to vasoactive agents like angiotensin II, and an increased response to nitric oxide, for instance. When systemic vascular resistance drops, afterload drops. And the drop in afterload stimulizes baroreceptors in the cardiopulmonary and renal system, who again stimulate sympathetic nerve fibers and lead to an increase of heart rate. That's why we find an increased heart rate in pregnancy. Due to the reduced afterload, we also have an increased stroke volume. And we know that the product of stroke volume and heart rate is cardiac output. So these are the most crucial changes that take place in the maternal physiology from very early on. Here you can see the comparison of cardiac output pre-pregnancy state and how it is increasing throughout the first trimester, and then by 16 to 20 weeks, it's stabilizing and it's staying high up to almost the end of pregnancy. Here we find an overview of all the hemodynamic parameters in pregnancy. We know about the cardiac output now, stroke volume and heart rate we have discussed. We know that there is a drop in mean arterial pressure. And because of the drop of mean arterial pressure by the vasodilatation, preload drops as well. And the preload drop necessitates a plasma volume expansion, which is most pronounced in the second trimester. And the plasma volume that is expanded in women is between 1.1 and 1.6 liters. This is how the cardiac output can be increased. And we know that the left ventricular mass in pregnancy is increasing throughout gestation, and it's highest in the beginning of the third trimester. So pregnancy is a cardiovascular stress for the mother. We have hemodynamic changes like peripheral vasodilatation, increasing cardiac output, and a reduced peripheral vascular resistance. But we also have cardiovascular adaptation. So there's concentric hypertrophy, increased left ventricular mass, and reduction in myocardial relaxation. This is a study that looked at echocardiographic parameters of fetal heart anatomy throughout gestation, and you can see across all trimesters how the anatomical sizes of the heart actually change. There's an increase in left ventricular mass, an increase in left atrial diameter, there's an increase in stroke volume and cardiac output, and there's a decrease in isovolemic relaxation time. And all of these changes are significant across trimesters in normal pregnancies. But why does it all matter? We know that cardiovascular disease complicates roughly 1 to 4% of pregnancies. And if you include high blood pressure disease in pregnancy, the prevalence is even higher. It is one of the leading causes of maternal mortality. And maternal death from cardiovascular disease has risen from 3 to 15% in the last 30 years in the developed countries. And the major cardiovascular risk factors is advanced age, because women are deferring the age of their first child. So their mothers are getting older. Obesity, chronic hypertension, smoking, diabetes, and also ethnicity. And what complications do we face? We have maternal complications that we are all aware of, gestational hypertension, preeclampsia, eclampsia, but there's also the risk of hypertension and cardiovascular disease for later on in life. And we have fetal complications that we have heard about, fetal growth restriction and stillbirth. So what about the hemodynamics in pregnancy with SGA fetus, with and without FGR? For this, we have to consider fetal growth restriction from a different perspective. We have heard earlier that fetal growth restriction is caused by uteroplacental insufficiency. Let's take one step back. Let's look at it as a result of inadequate maternal cardiovascular adaptation. Maternal hemodynamics in pregnancy needs to be looked at from a different perspective. So if you see a baby born, let's say at 38 weeks, you will see a baby maybe 2.3 kgs. So what do you think, and as an obstetrician, it's a term baby that is small but healthy, most probably. If you don't have any longitudinal measurements of that baby in that pregnancy, you don't know how this baby ended up being on the maybe 3rd, 5th centile when it was delivered. It might be, like shown on the graph on the right side, an SGA baby that has just developed normally, has been following its growth charts all the time, a normal but small baby born to a normal, healthy mother without any IUGR. But you might as well have a baby in your hand that has been on the 50th centile at around 20 weeks. And at some point, growth had slowed down due to whatever factors. And then at some point, growth had completely stopped. And then you have a baby in your hand, which is severely growth restricted, that has a higher perinatal morbidity and mortality, and the mother that has a high cardiovascular risk. But at the time when you deliver this baby and you know nothing about the pregnancy, you don't know what had happened before. So let's take it to pre-pregnancy. We have two pregnant women here. It is Sarah and Lisa. Both of them are fit and healthy. They can both exercise. They are not aware of any medical condition. And what we know is that Sarah, she already has some underlying cardiac dysfunction that she's not aware of in her daily life, and she has a hypovolemic state. So now they get pregnant. What happens in Lisa's body is that there is a full cardiovascular adaptation. So her cardiac output increases, her total vascular resistance drops, her preload increases, and pregnancy is developing normally. In Sarah, however, cardiovascular adaptation doesn't take place properly. So there is no increase in cardiac output, and her peripheral vascular resistance stays high. And this leads to a trophoblast impairment. We have heard about the transformation of spiral arteries before. We know that spiral artery transformation is one of the key processes in order to transform uterine vessels from high resistance to low resistance vessels in order to facilitate uterine and placental blood flow. And this has to take place in an orderly way so the trophoblast invasion can develop normally. But what if the trophoblast doesn't receive enough blood? So the previous explanation for high uterine artery resistance or an impaired spiral artery transformation used to be that there is impaired trophoblast invasion. But there is now current evidence that it is all caused by uterine malperfusion. And due to this uterine malperfusion, the trophoblast can't work properly. And that's why the uterine arteries remain high in resistance. And we know that these predisposes women to preeclampsia. But we have current evidence now that even from pre-pregnancy on, there is associated risk in women who have impaired maternal cardiac function to develop preeclampsia and also fetal growth restriction. But let's go back to our women. So we have Sarah and Lisa. They carry on with their pregnancy. They come for their anomaly scan in the second trimester. Both of them have nicely grown fetuses at 24 weeks. Both of them develop normally because at this stage, the fetuses are relatively small, physiologically small, because there is quite a lot of placental volume and quite small fetus. So in Lisa, we have an increased cardiac output. We have still a preload going up. We have reduced vascular resistance, but in Sarah, none of this is taking place. So what happens next? We go on to the third trimester. And in the third trimester, fetal demand really increases because the fetus grows. And at that point, we see that in Lisa's baby, where all her cardiovascular system is coping well with the pregnancy, cardiac output is going up, peripheral resistance is still down, and her fetus is developing normally, shown in the blue dotted line, growing along the centile. But in Sarah's baby doesn't receive enough supplies because the placenta doesn't do the job, because the spiral arteries have a high resistance to flow. Her body is not coping well with the pregnancy, so she's ending up with an FGR baby that has a high risk of intrauterine demise if not diagnosed early enough. We know from studies that are more than 20 years old that in pregnancies which are complicated by IUGR, mothers have a higher total vascular resistance. And the same was shown for fetal heart rate, for maternal heart rate, stroke volume, and cardiac output. So this Italian group looked at mothers with IUGR babies, and they found that all these mothers, compared to controls, had significantly lower cardiac parameters than normally developing fetuses. And also the preload in these mothers. The preload and the left atrial diameter in normal pregnancies was significantly higher than in IUGR complicated pregnancies, and the same was true for left ventricular dimensions. And this is because there's the lack of preload, a lack of plasma volume expansion didn't induce the heart to grow and to actually expand with the volume. There's another study which is very interesting. They looked at women who wanted to conceive. So these women were not pregnant when they were entered into the study. They assessed these women, and they collected a lot of cardiovascular parameters before they got pregnant. There were more than 500 women included, and more than 300 actually got pregnant within a certain time. And they followed these women up during pregnancy. And most of the pregnancies, they went fine. But some of these women obviously developed preeclampsia, and some developed fetal growth restriction. And then they looked at those who developed preeclampsia and fetal growth restriction. And you could see that women who developed fetal growth restriction, they had a lower cardiac output and a lower stroke volume even before pregnancy. They had higher total vascular resistance, and they had higher mean arterial pressure before they even got pregnant. So there is something in the maternal heart that is there before they get pregnant that predisposes them to develop fetal growth restriction. This is another study that looked at maternal cardiovascular impairment of severely growth-restricted babies. And the growth-restricted cohort is the yellow one. The red one is the one that has the preeclampsia with FGR. So the ones that that present with high blood pressure, the full picture of preeclampsia with fetal growth restriction. But the yellow one, this is normotensive women with fetal growth restriction. And they found that in this group, women present similar changes in cardiac ventricular function like those with preterm preeclampsia and fetal growth restriction. But it's just a small baby. Maternal cardiovascular function is affected by preeclampsia, we know that, but it might as well be true for fetal growth restriction, but just to a little bit lesser extent. So there is a cardiac function present pre-pregnancy, and the women with the poorest cardiac function pre-pregnancy have the highest risk to develop preeclampsia. If the cardiac function is not that poor, they might maybe only develop fetal growth restriction. Early in pregnancy, cardiac function needs to adapt to pregnancy, and if the body can't cope with the additional stress of pregnancy, then by mid-gestation, cardiac function will deteriorate and women will develop preeclampsia. And after delivery, most of these women, they will drop their blood pressures again. So blood pressures might even normalize. but we know that the cardiac dysfunction persists postpartum, even if blood pressure levels are normal. Also, the ESOC guidelines, which was revised in 2020, now takes maternal cardiovascular hemodynamic status into account as one of the clinical characteristics in the diagnosis of early and late fetal growth restriction. So it's one of the factors that is already included in the guidelines. So this is something that we have to bear in mind. From our work at King's College, we have also demonstrated maternal hemodynamic and fetal weight have a linear association even in uncomplicated pregnancies. So even in normal women, let's say, we found an association between cardiac output and estimated fetal weight. So the lower the cardiac output, the lower the fetal weight, even if it was within normal ranges. And the same was true for peripheral vascular resistance, but in an inverse relationship. So the higher the peripheral vascular resistance, the lower the fetal estimated birth weight in normal uncomplicated pregnancies. Very similar data can be shown for ophthalmic artery at 35 to 37 weeks. We have heard from Professor Nicolaides yesterday that the ophthalmic artery, that blood flows can be used to estimate the risk for preeclampsia in the first trimester, and you can also assess flow in the uterine in the ophthalmic artery in the third trimester. And we found that there is similar changes in blood flow in SGA and FGR pregnancies, like in hypertensive disorders, but just less pronounced. And also that the ophthalmic artery blood flows is related to birth weight centiles. So, and I think if you can see changes in the ophthalmic artery, this is the perfect proof that it's not the placenta that is causing the fetal growth restriction. The placenta is just affected by the maternal cardiovascular system, because the ophthalmic artery is far away from the uteroplacental unit and is still showing signs of dysfunction in hypertensive mothers, in mothers of FGR babies and preeclamptic mothers. And now we have to look at SGA. So maternal hemodynamics in SGA mothers, where the source of FGR mothers is different. We know that SGA babies are small, but they're small and healthy, and their mothers are healthy. Because a smaller person, a smaller mother, also has a lower cardiac output because she's a smaller person. But as long as her body adapts to the pregnancy, and as long as her placenta develops normal, her baby will be fine, even if the baby is growing on the 8th centile. And this group assessed heart rate, cardiac output, stroke volume, mean uterine artery resistance in FGR pregnancies and SGA pregnancies. And you can see that it is just the FGR pregnancies that have significantly lower heart rate, lower cardiac output, and higher resistance than compared to the SGAs. So it's not the SGA pregnancies we have to be aware of maternal hemodynamics, is FGR. The changes in FGR versus SGA is that in FGR pregnancies, you have low heart rate, low cardiac output, higher resistance, low ventricular mass. And in SGA and in normal grown pregnancies, the changes are the same. So mothers present with the physiological changes in SGA pregnancies, but not so in FGR. We also have a postpartum legacy for FGR. We know that there is a risk of cardiometabolic disease for preeclampsia, which includes coronary heart disease, stroke, hypertension, cardiovascular events, but as well as diabetes and vascular dementia. But we also know that the same is true for FGR. And it is even related to the severity and the gestation when the FGR baby was delivered. The earlier and the smaller the baby was at delivery, the higher the cardiovascular risk for the mother. And it's roughly 2 to 3-fold increased compared to a normal population. So I want to close with that. It is not just preeclampsia, but it's also fetal growth restriction that creates this scenario. And we have to take care of mothers of fetal growth restricted babies as well. Cardiac function in pregnancy mostly reflect underlying cardiovascular risk profile. The assessment of cardiac function in pregnancy and postpartum is important to identify those at risk. And women with FGR babies, with or without hypertension, they should receive adequate counseling and prevention of cardiovascular disease, because cardiovascular disease in women remains understudied, underdiagnosed, underrecognized, and undertreated. And it is our duty as doctors to identify these women and to diagnose them in order to help them to reduce the cardiovascular risk. Thank you very much for the invitation to talk. These are just some images from my hometown, Innsbruck in Austria, our university clinic in winter, when we have snow in the valley. The other photo I just captured a couple of days ago. And this is my fetal medicine team in Innsbruck. Thank you very much for the invitation. And I'm enjoying this program.